So that's what Hirschsprung's. Coming to Hirschsprung's disease, here what happens is this. See, normally the entire neuronal plexus, when we talk about embryogenesis, there's a enteric neuronal plexus which is formed, and these develop from the neural crest cells. And once the plexus is formed, they migrate into the bowel wall, okay, during embryogenesis. What happens is when there is normal migration of these neural cells, it is from the cecum to the rectum, so it is distal migration. When this normal migration is arrested prematurely, or when there are ganglion cells are arrested, undergo premature death, this results in aganglionic megacolon, and this is congenital. So when there is normal migration of the neural crest cells is arrested prematurely, or when these ganglion cells undergo premature death, it results in congenital aganglionic megacolon. So what happens here is, when this happens, the distal intestinal segment where there are no ganglionic cells, they lack both the Meissner's and the Orbach myentic plexus, resulting in a segment of the colon having no ganglion cells, or what we call as aganglionosis. So what happens here is there is dilatation proximal to this affected segment. So the affected segment is narrowed and the proximal segment is dilated. And hence what happens clinically, there is peristaltic contractions which have to be coordinated is absent, and hence even though there is no physical obstruction, there's a functional obstructions that occurs. Okay, so because of lack of ganglion cells in a segment of the intestine, there's narrowing of that part, and the part of the intestine that is proximal to it is dilated, and functionally there is an obstruction or a functional obstruction that occurs, and the coordinated peristaltic contractions are absent. Okay, so the congenital form is characterized by congenital absence of ganglion cells in the bowel cells. This is called as Hirschsprung's disease. And as I told you, the aganglionic segment is contracted, the segment proximal is dilated. How do they present? They are seen shortly after birth. They present with constipation, gaseous distension, and sometimes intestinal obstruction, because there's a functional obstruction that you see. And the cause is usually unknown, probably genetic, because it is seen in families or in monozygotic twins. And the incidence is around 1 in 5,000 live births. Okay, so how do we diagnose? Coming to the diagnosis, one very important thing is, in almost all the cases, always rectum is affected. Okay, the rectum is most probably affected. The other segments of the colon, they may be affected in various lengths or in various other ways. We'll come to the classification later. So usually what we take is a full thickness rectal biopsy, which includes the mucosa and the submucosa. Okay, at least it should include the mucosa and the submucosa on a suction biopsy. Or second thing is, the better one is to take a distal narrow segment that is aganglionic, and a proximal segment that contains number of ganglion cells. We need this for a comparison. Okay, so there is a distal aganglionic segment and the proximal dilated segment, both need to be biopsied for diagnosis. And what do you see on microscopy once we biopsy this? You have to see the distal narrow segment has a total absence of ganglionic cells in all the three plexus, the Orbach's or the myentic plexus, and the two muscularis layer, the Henle's plexus and the Meissner plexus. Prominence of non-myelinated fibers is again seen, and IHC markers can be used to confirm, first to stain for acetylcholine esterase activity. Okay, and to identify the ganglion cells and the nerve trunks. Okay, coming to the forms, the most classical form what we come across is the aganglionosis from the distal colorectal till the proximal dilated colon. Okay, this is the most classical form, but the other forms of aganglionosis can also be seen in Hirschsprung's. And the other segment is a short segment where there is rectal and rectosigmoid involvement. Okay, so the narrowing or the aganglionic segment is limited to the rectal and the rectosigmoid. Sometimes there could be an ultra short form where aganglionosis is in a very small segment, very small segment. It could be missed on a biopsy. And a more severe form is the long segment or the subtotal colonic form, where it involves most of the colon from the rectosigmoid till the ileocecal valve, and it may sometimes extend into the small bowel too. Other than that, you can also have zonal. So you can have alternating areas of ganglionic and aganglionic segments. Okay, so these are the 5 types or the 5 forms that you can encounter. Okay, one more important before we go on to the differential diagnosis of megacolon is Hirschsprung's. Most of the time, this is one more important specimen that we get for frozen section. So when the surgeon decides on table how much of the segment we taken out, so the proximal narrow segment is taken, but there is always some on table confirmation that is sought to see whether enough bowel is removed. So the surgical margins should show ganglion cells. That is when you say the surgery is complete or the resection of the aganglionic segment is complete, when you see the ganglionic cells at the surgical margins. This is one more thing that you need to remember. Okay, so Hirschsprung's disease, it's congenital or acquired, and this is loss of ganglion cells. Most commonly, the loss of the aganglionic segment is narrowed and the proximal segment is dilated. When the segment of intestine has to be resected, always make sure the surgical ends do show ganglion cells. You can do it using a frozen section, and that is indication that the aganglionic segment is completely removed. Okay, this is another very important question you could get as a 5 marker in your exam, so read about it. Other causes of megacolon, I told you it is not just megacolon. This is not specific to Hirschsprung, so there are many other causes. First thing, it could be obstructive causes like a tumor or a post-inflammatory strictures, like in many of the inflammatory bowel diseases that we have seen. So proximal to the stricturous part, you could probably have a dilated segment causing megacolon. Then again, megacolon is also common in mixed edema or cretinism. These are the endocrine causes, and also in CNS disorders like spina bifida, paraplegia, Parkinson's, where the plexus is affected. It has also been noted in some psychogenic disorders. Chagas disease is another example where you see a megacolon. You must have read this already. And here it is due to infection of Trypanosoma cruzi and is the only example resulting in acquired loss of ganglion cells. Okay. Next, coming to the only segment of GID that we are left with is the large intestinal polyps and tumors. Here I would also be covering few polyps which could affect the small intestine too. So I've clubbed it. So we will be basically talking about the intestinal polyps and the colorectal carcinomas from now on. Okay. So first of all, coming to the classification, you have neoplastic and non-neoplastic polyps. In neoplastic, again, you have benign and malignant. In the non-neoplastic polyps, these are something that you really have to know. These are something that you will come across more often. There are hypoplastic polyps, Hamartomatous polyps. Again, under Hamartomatous, you have the Peutz Chagas polyps and the Juvenile polyps. Other than these, we already spoke about inflammatory polyps or the pseudo polyps when we discussed inflammatory bowel disease. And another set of polyps that we can encounter is the lymphoid polyps. These are the non-neoplastic polyps that are most commonly seen in the intestine. Okay, coming to neoplastic polyp based, this is adenomas. This is purely based on the architecture, but they also behave differently. Okay, they also clinically behave and prognostically they are different. So we have tubular adenomas, villus adenoma, and tubular villus adenomas. Coming to familial polyposis syndrome, you have familial polyposis coli, and you also have polyps as a part of the other syndromes like Gardner's, Turcotte's, and juvenile polyposis. Okay, these are the familial syndromes where we could also encounter the adenomas. Other benign colorectal tumors could also include leiomyomas, leiomyoblastoma, neurulomoma, lipoma, and vascular tumors, but these have the same morphology like how we see anywhere else in the body. So I'm not going to discuss these in details. What we are going to discuss again is the malignant colorectal carcinomas, where adenocarcinoma is the most common, adenocarcinoma and its variants. Okay, and other malignant tumors could also include lymphomas, carcinoid tumors, malignant carcinoid you mean, and leiomyosarcomas. We discussed carcinoid tumors in the last class. Okay. Next, and another special variety, or we do classify tumors of the anal canal separately because there is this is a different entity where we have viral warts and or condyloma accumulata that is encountered more often in anal region, and the malignant subset includes the squamous cell carcinoma, basiloid carcinoma, mucoepidermoid, undifferentiated, and malignant melanoma. Yeah, because the lining is different from the large intestine. So coming to non-neoplastic polyps, we told they could be hyperplastic, hamartomatous, and lymphoid polyps. And hyperplastic polyps is the most common among all the epithelial polyps and more common in the rectosigmoid. Okay, so what is hyperplastic here is there is hyperplasia of the epithelium at the base of the crypts. Okay, and this results in cystic metaplasia. This can be seen in any age, but they're more common in the elderly. Grossly, these are multiple, but could be sessile and smooth surfaced, and they're less than 0.5 centimeters. And microscopically, they're long and cystically dilated glands, and crypts can be lined by normal epithelial cells. Lining is flat and could be papillary. It may not be a true papillary, it could be pseudopapillary again because of the hyperplasia. And the luminal border of the lining epithelium is usually serrated or sawtooth. And unless there is a coexistent adenoma, usually hyperplastic polyps do not have any malignant potential. They don't turn malignant. Okay, it is separate. If it is just a hyperplastic polyp, their malignant potential is very, very low. But with a coexisting adenoma, yes, it could turn malignant. Hematomatous polyp is, what is hematoma? There's an abnormal mixture of tissues indigenous to that part. Okay, these are mature tissues. So the two types are Puce Jaeger and Polyposis, and both these are inherited autosomal dominant, and they are characterized by hematomatous intestinal polyps, melanotic pigmentation of the limbs, mouth, and genitalia. Grossly, they are of variable size. These are not small like the hyperplastic polyp. They could be of various size, but they are large, multiple, and pedunculated. And this hematomatous polyp, that's why I told you I'm clubbing the polyps, even the ones which can occur in the small intestine. This is more common in the small intestine. You have to remember that. Okay, hematomatous polyp are more common in the small intestine. And they have a very characteristic feature on microscopy. You can actually make out the tree branching appearance of the muscularis mucosa. Muscularis mucosa is what is in the mucosa just below the lamina propria. Okay, the lining epithelium is normal, but the glands show hyperplasia and cystic change here. I'll show you the picture. And again, these do not undergo any malignant transformation unless there is a coexistent adenoma. So all these hyperplastic hematomatous, the non-neoplastic polyps, they do not undergo, they have no malignant transformation unless there is a coexistent adenoma in the adjacent area. However, it is only the Puce Jaeger which can be prone to certain other cancers, okay, of the pancreas, lung, breast, ovary, and the uterus. Okay, so this is a pictorial representation. If you can make out the tree branching appearance of the muscularis mucosa, if you can see the muscularis mucosa here appears plain, and the tree branching appearance is, this is a actual HD picture. So you can make out the muscularis mucosa. This is just the mucosa where you have the lining epithelium, submucosa, and the lamina propria and the muscularis mucosa. Showing a tree branch appearance of the muscularis mucosa. Time to gota hai. Juvenile retention polyps, these are another form of hematomatous polyp, but what is important here is like how the name says, it is common in children and usually they are below 5 years of age. And the solitary polyps occur more often in the rectum, okay? And it can be, it can be present anywhere, but it is more common in the rectum, okay? Stuck up. Grossly, they are spherical or smooth surface. They are about 2 centimeter, most commonly pedunculated. Microscopically, the classical appearance, you can see the cystically dilated glands, and these glands are lined by mucus secreting epithelium, and they also have mucus. And another important thing you have to notice, there could be chronic ulceration and inflammation. So this is the polypoid structure, and these are the cystically dilated glands that you would see. This is a pictorial representation, and this is the actual H&E picture. So this is the cystically dilated glands that you're seeing within the mucosa. Coming to inflammatory polyps, we've already discussed it. This is more common in ulcerative colitis, sometimes also seen in Crohn's disease. These are pseudo polyps, as we have already studied. It is due to reepithelium of the underend. There is ulcer, and reepithelialization of the ulcer or the swelling of the adjacent mucosa, giving it a polypoid appearance. These are not true polyps in the actual sense. Okay, and these are multiple rounded overgrowths of mucosa. Okay, and microscopically there is no fibrovascular core here. The center of the inflammatory polyp consists of a connective tissue core and some inflammatory infiltrate and covered by regenerating epithelial cells. That is most important, the regenerating epithelial cells and some cystically dilated glands. When we talk about lymphoid polyps, what is striking here in these polyps is they're normal in rectum and thymular limb. There is reactive hyperplasia of the lymphoid tissue. This could be localized or diffuse, and that's why they're called as rectal tonsils. Okay, and more in the elderly in the localized form, and the diffuse form is more common in younger age and the children. These are again solitary and multiple tiny elevated lesions, and there is prominent lymphoid follicles with germinal centers located in the submucosa and the mucosa. These can be covered with an epithelium that can be normal or an inflamed epithelium. Okay, they have to be distinguished from malignant lymphoma. So this is how it looks. You can see there's a polyp, this is a solitary form. Okay. Coming to neoplasms, the neoplastic polyps, what is important here is these are neoplasms, but they have a very, very high potential to turn malignant. It could be tubular villus and tubular villus. When we talk about tubular adenoma, this is the most common neoplastic polyp. These are the most common among the neoplastic polyps, common beyond the third decade of life and more common in males. Again, involving rectum most commonly and the distal colon. The rectum and the rectosigmoid again is the most common area here. And these can be found singly as sporadic cases, or there can be multiple adenomas as a part of familial polyposis syndrome. And when we see that, that has a autosomal dominant type of inheritance. They could be single or multiple, sessile or pedunculated. So they could be any size and shape. And spherical masses, they have a very irregular surface. Microscopy, there are branching tubules which are embedded in the lamina propria. This is what you are going to pick up. Okay, the branching tubules, and these tubules could be embedded in the lamina propria. And the lining epithelial cells are the large intestinal type with mucus secreting capacity, but it is diminished. And what is one more thing that you have to look for is the mitotic activity, the nuclei, and the varying degree of cytologic atopia. And here again, they have a high chance of malignant transformation. Villus adenoma on the other side, it is more common in the 6th decade. It's at a later age group than the tubular adenoma. Again, distal colon and rectum are the most common sites, and they do show round to oval exophytic masses, sessile, varying in size from 1 to 10 centimeters. Surface here could be ulcerated or hemorrhagic. But microscopically, what you notice is the tiny finger-like villi or slender villi. Okay, and these look like they're arising directly from the area of the muscularis mucosa. Each of these villi, they are true villi. They do have a fibrovascular stromal core, and they are covered by epithelial cells. What is again striking here is, unlike in the hyperplastic or the Chagas polyp, the non-neoplastic polyps, you look at the epithelium, there could be varying degree of anaplasia. There could be atopia, and sometimes it could have carcinoma in situ changes or invasive carcinoma more frequently. Invasive carcinoma again very, very, very common in villus adenomas. Tubular villus is something in between these two patterns. Okay, they could be have tubular glands and also villus or slender papillae that could be seen, but these are smaller compared to the villus adenoma grossly. Okay, and they do have an intermediate, or most commonly we see a mixed pattern where you have vertical villi and the deeper part showing tubular glands. Okay, this table is very, very important. It's there in all your textbook. It's very, very important because tubular adenomas and colorectal carcinomas are very frequently asked question in your exams, in your entrance exams, and we have a lot of specimens slides, so you will be questioned anywhere, and this table is very important, so you better be familiar with this. Okay, so non-neoplastics is more common, and they have less malignant potential, but neoplastic, even though they're less common, they have more malignant potential. Okay, and now when we come to number, non-neoplastic are mostly sporadic. Familial predisposition is more common in neoplastic polyps. And when we come to type, hypoplastic, we already discussed. This is the most common type. Other than that, we have hamartomatous and inflammatory and lymphoid polyps. In neoplastic, we have three patterns: tubular, tubular villus, and villus. Familial syndromes, we have discussed. There could be familial syndromes associated with both types of polyps. And biological behavior, neoplastic or adenomas tend to turn malignant more commonly, but non-neoplastic do not unless they are associated with adenomas. So this is a summary of that we have seen. This is the branch tubular glands, the tubular adenoma, this is the villus, and this is the tubular villus. Okay, pattern. Coming to familial polyposis syndrome, there are few syndromes where multiple polyposis of the comb is a part of it. And whenever we talk about familial polyposis syndrome, most of the time it is autosomal dominant inheritance. So, recollecting our genetics class, so one mutant allele could manifest the disease in the next generation. So important conditions are familial polyposis coli, Gardner syndrome, Turcot's, and juvenile polyposis syndrome. Okay. Chagas we already discussed, and Cronkite-Kendall syndrome also could have multiple polyposis in their intestines. Familial polyposis coli is inherited in an autosomal dominant fashion. The definition, this is very, very important. There could be more than 100 neoplastic adenomas on the mucosal surface of the colon. You will see they are studded with polyps. Once a segment of the intestine is open or on endoscopy, you can see it is studded with polyps. And this should be distinguished from other multiple adenomas. Other multiple adenomas, the neoplastic ones, usually do not have more than 100. Okay, but the familial one, yes, does have more than 100 or hundreds of them. And what is the etiology here is the germline mutation in the APC gene, which occurs, which progresses to adenomas and then to cancer. We'll talk about the pathogenesis a little later. And here in familial adenosis, the average age at diagnosis second to third decades and equal incidence in both the sexes because it is autosomal dominant inheritance pattern. And most of them are tubular adenomas, and hence the malignant potential is very, very, very high. And virtually 100%, most all the cases by the age of 50 years, they do develop colorectal carcinomas. That's why once there's a family history of familial polyposis coli, usually there is a prophylactic colectomy that is done much. There's a screening and prophylactic colectomy that is done to prevent the occurrence of colorectal carcinomas. Okay, studded with polyps. The mucosal surface is studded with the multiple polyps and they are pedunculated. Okay, this is, you can make out there are multiple tiny polyps. This is one, the bigger one is one dominant polyp of those multiple polyps. If you can see in this one field, you have the tubular adenomas, 3 of them, and this is something with a lymphoid hypoplasia too. Okay. The other syndromes are Gardner syndrome. What are the components of Gardner syndrome? You have familial polyposis coli, and extracolonic lesions include multiple osteomas, sebaceous cysts, and connective tissue tumors. In Turcot's, you have familial polyposis coli again, and CNS tumors. Coming to juvenile polyposis colon, this is a little rare compared to the familial polyposis coli, and their appearance of multiple juvenile polyps in the colon, the stomach, the small intestine. This is much more extensive involvement. Again, it could be autosomal dominant inheritance pattern, and usually seen, they're recognized by 5 years of age. And the very good thing about this is they don't have a higher malignant potential like how we see in the familial polyposis coli. So this is another table that is depicting all the gastrointestinal polyposis syndrome. I have elicited a few important ones. Okay, you can go through this table later. Okay, coming to the most important and the last part, malignant colorectal carcinomas. And colorectal carcinomas comprise 98% of all the malignant tumors of the large intestine, and the mean age of the patient is around 60 years. So male is to female ratio is 2:1. Okay, other locations in the large bowel and the overall incidence is equivalent in both the sexes. Etiology, there could be geographic variations where it is more common in North America. And again, diet playing a very important role in these races. Low intake of vegetable fiber diet leading to low stool bulk causes higher risk of colorectal cancers. And consumption of fatty foods, excessive fatty foods, again are with metabolites which are carcinogenic. Excessive consumption of refined carbohydrates, which alters the bacterial flora, resulting in carcinogenic material. Most important is the adenoma carcinoma sequence. This is the pathogenesis. We'll discuss it in detail in the next few slides. We know that there's a high risk of carcinomas developing from adenoma. So this is the adenoma carcinoma sequence. You've already discussed in neoplasia. We will discuss the highlights in the next slide. Okay. So there is early invasive cancer, and the hypothesis is we have already noticed there could be early hyperplasia, which could be displaced, which could lead to dysplasia, carcinoma in situ, and invasive carcinoma. And when we are seeing slides of invasive carcinoma, we do see areas where there is in situ carcinoma and there is hyperplasia and metaplasia. So that actually boosts the pathogenesis here. Okay, and incidence in adenomas, again in populations where the incidence of adenomas is directly proportional to the prevalence of colorectal carcinoma. So that is another hint to say that the adenoma carcinoma sequence is what is working here. Okay, and adenocarcinoma colon declines with the endoscopic removal of the identifying adenoma. That is, especially in familial polyposis coli, we already spoke about the prophylactic colectomy, which reduces the incidence of colorectal cancers. Okay, and peak incidence generally precedes by some years, and peak incidence for colorectal carcinoma. And the risk of malignancy increases with number of adenomas. So more adenomas, more risk. Size of the adenoma, larger size, more the risk. And the type of adenomas. Villus is a higher risk than the tubular. So this is how it progresses. Mucosa at risk, then hyperplasia. Then you see the next step is adenoma and dysplasia, carcinoma in situ, and invasive carcinoma. And what you have to remember here is the most important mutation. One is the APC gene on the long arm of chromosome 5, and then RAS gene on chromosome 12p, and P53 gene along with the DCC gene that we'll be discussing later. And hereditary non-polyposis colonic cancer or Lynch syndrome, again this is autosomal dominant inherited, and it is seen in at least 2 generations. And here one more important thing is, with every generation the occurrence is at a much earlier age. And the most important mutation here is the mutation in the mismatched human repair genes, that is human mutation on homolog 2 on chromosome 2. It is resulting in DNA instability. So colorectal cancer here appears at a relatively younger age, and there are multiple primary cancers in different sites again other than the colon, but the preferred location is the proximal colon. But what is very important is this has a better prognosis than the sporadic colonic cancers, HNPCC. And a pre-existing disease like ulcerative colitis or diverticular disease, they again increase the risk of colorectal cancer. Again, tobacco smoking has also been implicated in the colorectal carcinoma, especially in the younger patients. So coming to the genetic basis, this is again very, very important, usually asked question, or Colorectal carcinoma comes as a main question too. So where you will have to kind of discuss the genetic basis of colorectal carcinogenesis. At least you need to mention and give the highlights of the three mechanisms that we are going to discuss now. Okay, so there is a sequence multi-step mutation in the evolution from adenoma to carcinoma, and it is one of the two or the three mechanisms that we are going to discuss now. One is APC beta catenin mechanism. So this pathway of multiple mutation is generally associated morphologically identified changes. So when it is this pathway, we can actually see the morphological evolution from normal to hyperplasia to dysplasia to in situ to invasive carcinoma. So what happens here is the first hit, it could be the first hit is the loss of tumor suppressor gene. This could be congenital or this could be applied, but this is the first hit. Okay, and one more very important thing is for a colorectal carcinoma to be manifested in its fullest form, you have to have both the alleles. Even though it is autosomal dominant, you need both the alleles to be mutated. So the first hit is already there, congenital or acquired, in the loss of tumor suppressor APC gene, which is on the long arm of chromosome 5. This is present in most of the cases, 80% of the cases. The colorectal carcinoma develops when there's the second hit in the same gene, which is linked to beta catenin. And loss of this, there is translocation of beta catenin to the nucleus, activating the transcription of the other genes, mainly the MYC and cyclin D1. Together, what they're doing, they are stimulating irregular cell proliferation. So mutation in the APC gene, loss of APC gene, translocation of beta catenin, activation of transcription factors MYC and cyclin D1, and irregular cell proliferation. The second part is the point mutation in KRAS gene. Okay, this follows the mutation of APC gene. So this is following the second hit, the mutation in KRAS and deletion of the colorectal carcinoma gene, or the DCC gene, on long arm of chromosome 18. This again occurs in 60 to 70% of the cases. The last part in the pathogenesis is loss of the tumor suppressor gene P53. Okay, so this is how we deal. All these can manifest in morphologic changes too. Okay, first there is here, the first is loss of tumor suppressor gene early. This could be congenital to this, so they can be born with one mutant allele and this they are extremely poor, or this could be acquired also. And later there is methylation abnormality. This is the second stage where the beta catenin pathway occurs, as we discussed before. Then this makes the this puts the mucosa at rest. This is already the second hit. Along with it, there are other proto-oncogene mutations like KRAS at chromosome 12 and the homologous loss of additional cancer suppressor gene, the P53, the LOH and the SMAD2. At this point, there is adenoma that is developed, even more prone to carcinomas. Then we go through the tumor suppressor gene P53, that is the most important, which leads to the emergence of carcinoma and the additional mutations which pile up and cause an invasive carcinoma. Okay. So this is most commonly, this is the order, but the order could be different, but what is important is the piling up of these or the accumulation of these mutations, which leads to the end result, which is the carcinoma. The other very important mechanism in colorectal carcinoma that you have to talk about is microsatellite instability. So what is happening in this pathway? See, there could be one pathway, that is what we spoke about, which could manifest APC beta catenin. It starts with APC beta catenin and accumulation of mutations. That is one pathway or one pathogenesis or one theory. Okay, where that is proven because we could also see the morphological changes along the way. The second mechanism is microsatellite instability, which can also cause colorectal carcinoma, but the pathogenesis is different. Okay, here what is happening is there are multiple mutations but of different genes. Unlike the APC mutation beta-catenin, here we do not see the morphologically identifiable changes unless till the end. We can't pick it up in the earlier stages. It is already in the invasive state by the time we pick it up when it is following this mechanism. Okay, here the basic mutation is the loss of the DNA repair gene resulting in repetitive DNA sequences, or what we call as microsatellites. So there are repetitive DNA sequences. They are becoming unstable during replication. Okay, they are becoming unstable, and this is the hallmark of this pathway. That's why it is called the microsatellite instability mechanism. And the significance of DNA repair is, see, the TGF beta receptor gene, so what, and the BAX gene. These are the two important genes that are implicated in this mechanism. What is the role of TGF beta? It normally inhibits cell proliferation. Okay, when this gene is mutated, it does not inhibit cell proliferation, but it causes uncontrolled proliferation of colonic epithelium in the adenoma. The second most important gene is the BAX gene. What does BAX gene do? We already know it's a pro-apoptotic gene. So when it becomes mutated, there is loss of apoptosis and dysregulated or uncontrolled growth here. Okay, so morphological changes are not very are not seen in this mechanism unless we reach this stage where it is already accumulated, all the mutations are accumulated, and then there's full-fledged carcinoma. Okay, so there is germinal somatic mutation, second hit, and then microsatellite instability mutated type, and there is accumulation of mutation, and by the time it is noticed, there's already in the invasive stage. Okay, so these are the two important ones that you have to talk about in pathogenesis. Coming to the morphological features, the distribution of primary colorectal carcinomas, it is more commonly in the rectum. Rectum is the most common site for everything, most of the things, so you'll be on a safer side to write that on your paper. Okay, and it is followed by sigmoid and descending colon, the cecum on the ileocecal valve. And the transverse colon is the rarest site where you could find colorectal carcinomas. Okay, transverse colon is the rarest. Rectum is the most common. Grossly, this is again very, very, very important. The right side colonic mass, the right side colonic growths, that is the ascending colon, and the hepatic flexure. These are large cauliflower-like growths, soft and friable masses. They project into the lumen. So right side growths are more fungating type. Okay, they are large cauliflower-like fungating type of carcinomas. But when we come to the left side, the rectum, descending colon, and the splenic flexure, these are more napkin ring configuration, or they grow circumferentially and they are ulcerating and narrowing. So we call these as carcinomatous ulcers. Okay, so the right side polypoid, left side constricting or napkin ring with carcinomatous ulcers. Why is this so? Because on the ascending colon, the contents of the colon are still liquidy and they have space, they leave space for the luminal growth of the tumor. But by the time it comes to the left side, it's more solid, there's no place in the lumen for the growth. So that's why it spreads circumferentially. Okay. So this is the right side where there is more, where this is more liquidy, the contents are liquidy, so there is more space in the lumen to form a fungating polypoid growth. But when by the time it comes, there is no space for the invasive carcinoma to get in, so it is more circumferential, or it is what we describe it as napkin ring configuration. Microscopically, they are both the same. Okay, microscopically both are the same. Most commonly it is an adenocarcinoma, like how we see in any other part, like how we have discussed till now. It could be well differentiated, moderately or poorly differentiated, but very rarely they could be mucin secreting colloid carcinoma too. Okay, and very few of them show uncommon microscopic patterns. Okay, this is a moderately differentiated where you're seeing tumor cells arranged in glandular pattern, and this is the muscularis propria. They're invading into the muscularis propria, and you can see the individual cells are showing high degree of atypia, high degree of cellular atypia, increased NC ratio, and there is stratification and also increased mitosis. Okay, so the morphology microscopically is the same like how you see elsewhere in the body. Okay. And this is one variant. This is a mucin secreting adenocarcinoma, where you see these glands form these tumor cells forming gland-like architecture. They're secreting mucin, which is accumulated within, and you can, as mucin pools everywhere, and these glands are playing through the muscularis mucosa, and you can see some signet ring cells. Signet ring cells are the cells with an eccentric nucleus and cytoplasm, which is filled with mucin. Okay. So when we come to how do these colorectal carcinomas spread or metastasize, it could be by direct spread, lymphatic or hematogenous spread. Direct spread is most common in both ways, the right and the left side, circumferentially into the bowel wall as well as into the depth of the bowel up to the serosa. This is very important because the staging system depends on the extent of the spread. Okay, lymphatic, okay, first to the region of lymph nodes and then into the other pre-aortic, internal iliac and sacral lymph nodes. Hematogenous, yeah, it could go to the liver, lung, brain and the ovary. This is the lymph node spread. This shows the lymph node spread where you see the lymphatic tissue and the adenocarcinoma, the metastasis, the glandular structures within the subcapsular sinus. And this is in the lung. The colorectal carcinoma metastatic to the lung causing a gray-white hemorrhagic nodule. Okay, this is liver containing metastasis. Multiple metastatic nodules with central necrosis. Okay. Clinically, how do they present? They come with occult bleeding or melena, change in bowel habits, loss of weight, loss of appetite, anemia, weakness, malaise. More common complications could be obstruction and hemorrhage. And perforation and secondary infection are less common. Diagnostic methods: stool test for occult blood, PR examination, proctoscopy, and radio CT scans and tumor markers in familial cases. A word on CEA, the carcinoembryogenic activin. This is elevated in 100% cases of metastatic colorectal carcinoma. So when metastasis is the first thing that is picked up, which is rare, but still CEA could come in handy to diagnose that this metastasis is of colorectal origin. And this could also be positive in 20 to 40% of early cases and 60 to 70% of advanced primary lesions. And these have prognostic significance more than diagnosis. So during treatment, you can monitor the CEL levels to see why it has more prognostic values, because it is positive in other cancers also, like in the lungs, breast, ovary, and urinary bladder and the prostate. One more important thing to remember is CEA levels are elevated in non-neoplastic conditions also. So clinical examination and other tests are also important. Ulcerative colitis, alcoholic cirrhosis and pancreatitis also show elevated nuclear CEA levels, but not to the extent of the neoplastic levels. Okay, coming to another important aspect of colorectal carcinomas, the staging and prognosis. First thing you have to remember is there are many variables that are implicated in the process. So you have to see what is the extent of bowel involvement, whether there is metastasis or not, histological grade of the tumor, and the location of the tumor. All these variables have independently, they affect the prognosis. Now, among these, the most important is the stage of the disease at diagnosis. That predicts the 5-year survival. So 3 staging systems that we use, that were used, actually Duke's system, that is modified Duke's and modified Duke's, astral collar, which is the modification of Duke's staging. These two are most commonly used, but now uniformly we use the TNM staging, okay, by the American Joint Society. So just a note about what's Duke system. Here there were four stages with multiple sub stages: A, B, in B, B1, B2, and C, C1, C2. This depended on the extent of the tumor. Okay, A1A or stage 1 was confined to the mucosa only, stage 2 or B1 was confined to the submucosa. When it comes to B2, it could muscularis plus the serosa. When it comes to C or the stage 3, it include the muscularis plus regional lymph nodes, or the serosa with regional lymph nodes. Stage D was when there was distant metastasis, and these affected the 5-year survival too. Okay, stage 1 had a better 5-year survival compared to stage D, and that was evident morphologically too. And then right now we follow the AJCC or the TNM classification for colorectal carcinoma. This is what we fill it in our report forms, and also for the CAP protocol that we report in. Okay, so this is a much elaborate system and a more objective one. So that is why it's used. Here it starts with TIS. IS means it in situ carcinomas. Then the T1 where the tumor invades the submucosa, T2 where it goes through but it is not completely splaying the muscularis. So it could be in the muscularis but is not going beyond the muscularis. T3 it invades and passes through the muscularis mucosa. Again there are subtypes depending on how much of the muscularis mucosa, how much beyond the muscularis mucosa the tumor is invaded. Less than 0.1, 0.1 to 0.5, more than 0.5 to 1.5 centimeter, and more than 1.5 centimeters beyond muscularis mucosa. So that we give us 3A, B, C, and D. Stage 4 when it has gone to the adjacent organs. So it has gone beyond the serosa and into the visceral peritoneum. Again, if it is only the adjacent organ system or the visceral peritoneum, it is 4A and 4B. Coming to that is T. T means the size of the tumor or the involvement. N is for the regional lymph nodes. So NX when we don't have the lymph nodes for assessment, N0 when we have the lymph nodes but none of them show metastasis. N1 is when one to three regional lymph nodes show metastasis, and N2 is when metastasis is there in 4 or more regional lymph nodes. Again, in M means distant metastasis. So MX is when we don't know or when we can't assess the distant metastasis on the specimen that is provided to us, and M0 and M1 when there is distant metastasis. Okay, this again has an implication in the 5-year survival stage, where 5-year survival stage in stage 1 is 93%, and then when it goes to stage 4 it is 8%. So tumors of the anal canal, we have already discussed all these in multiple conditions. Morphologically they are all the same. We will just list up here and say these are epithelial. Most of the time these are epithelial tumors. Here anal canal is lined by stratified squamous epithelium. That is the reason why the tumors are different here. They are not lined by the colonic epithelium, but it is the stratified squamous epithelium. So in benign tumors we have the condyloma aquilimata, and in malignant tumors we have squamous cell carcinoma, basaloid carcinoma, mucoepidermoid, adenocarcinoma, and undifferentiated and malignant melanoma. And the morphology of all these are like how you see elsewhere in the body. Okay. Yeah. To conclude, this is one more thing, or this is one more question that could be most commonly asked. What are the causes of GI bleeding? So I thought I'll put it up as the last slide here, as a concluding to the GI topic as such. Okay, in upper GI bleeding, you have the esophageal varices, erosive gastritis, marrow-reversal tear, the ulcers, duodenal and gastric, and CS stomach. Small intestinal bleeding, it could be the tumors, and drug-induced is very common here, Meckel's diverticulum, interception, Crohn's. And lower GI, it could be CA colon, rectosigmoid, hemorrhoids, anal fissure, and inflammatory bowel disease. So with this, I conclude the GIT topic. You can write to me if you have any doubts. And about the internal assessment, your internal assessment is announced. So most of the, we will be including, I have taken genetics too for you. So, and the topics I'll be including the whole of genetics and also GI system. Okay, so you be prepared for genetics and GI system for your internal assessment. Okay, all the best. If you have any doubts, you can write to me. Okay. Yes, you're not audible. You want to say something? Okay. Thank you. ನಾನು ಅಟೆಂಡೆನ್ಸ್ ತಗೊಂಡಿಲ್ಲ. ಸ್ಟಾಪ್ ಪ್ರೆಸೆಂಟಿಂಗ್ ಮಾಡ್ಬೋದಲ್ಲ. ಅಲ್ಲ ಸ್ಟಾಪ್ ರೆಕಾರ್ಡಿಂಗ್ ಆದ್ರೂ ಮಾಡಬೇಡ.